Hello all, and thanks a lot for the invitation. So the question today is hepatic encephalopathy underestimated? Let's start with the definition of hepatic encephalopathy, which is, as you know, a neurological trouble caused by acute or chronic liver injury or portosystemic shunt. And it includes clinically a very wide spectrum of abnormalities ranging from infraclinical abnormalities to coma. Here on this slide, you can see the last classification of HE, and of course, we won't go into detail in the classification, but you can see that there are several stages, 5, and that we use this classification in a binary way with patients displaying a clinical HE or patients displaying a non-clinical HE, and that's how we use it clinically speaking. Patients displaying clinical HE are patients really easy to diagnose, and we will see this just after. However, and their clinical spectrum ranging from hysterectasis, delirium, or coma. Patients with non-clinical HE are more cumbersome to diagnose, and they can have nothing at the clinical examination: sleep disturbances, euphoria, anxiety, attention disorders, and those patients are more difficult to diagnose. Clinical HE is frequent, and if we estimate that 400,000 patients display cirrhosis in France, we can envision that 20 to 30,000 of them will display clinical HE at the onset of liver disease. And a way to see if we correctly diagnose clinical HE is to look at the data of the medical insurance, and that's what we did between 2013 and 16. And what we showed is that 80,000 patients per year were hospitalized in France for clinical HE, and those numbers are in line with the prevalence we were expecting. That being said, I think that we can assume that we diagnose correctly clinical HE. Non-clinical HE is the issue here, and I think that this is non-clinical HE, which is underdiagnosed. Non-clinical HE includes minimal HE and HE grade 1. Minimal HE, it's nothing except abnormalities and neuropsychological tests, and grade 1 HE includes psychomotor slowing, euphoria, anxiety, sleep disturbances. And often the caregivers are saying that the patient is having the symptoms, and that's how you can detect it. However, when you look at the cognitive functions, you will expect a psychomotor slowing, attention disorders, short-term memory disorders, and alteration of executive functions. When you see the patient, you don't think that. You see that the patient tells you doing something is taking me longer than it used to. I often forget where I put my keys. There are times when it goes well and times when it doesn't go well at all. And the caregiver says, well, he gets angry more easily than he used to. And what you think is that he is so slow. And what is very important to note is that those troubles are worsening or fluctuating over time. The first thing to ask yourself is it important to diagnose non-clinical HE? Yes, it is important for several reasons. The first one is that non-clinical HE is a prognostic factor of the onset or recurrence of HE episodes, and which are impairing survival. The second thing is that it impairs quality of life and induces, in fact, a major deterioration in quality of life. And the last thing is that there are simple and effective treatments like plasma ammonia lowering therapies that can really improve the state of your patients. So yes, the question is really relevant. This is important to diagnose non-clinical HE. The first issue is that the diagnostic tools that we have at our dispositions are different depending on the countries, but there is no gold standard for the diagnosis. And here there is a list of the tests that are offered to you. Some of them are here. You know the FES, you know the CFF, and you know the Stroop test. Altogether, FES is taking 25 minutes at least, CFF 10 minutes if you have the device, and Stroop test, which is available, at least takes also 10 minutes. It's really widely used in US, not a lot in France, but it's taking time. And usually we don't have a lot of time. Moreover, those tests are not really specific of hepatic encephalopathy. The second issue, which is very important, is the minimization of troubles by the patients. And I will tell you 2 case reports from the same patients. This guy is 57 years old. He displays metabolic cirrhosis, HCC, and beta blockers for grade 2 EV is in this treatment. He's a former farmer, and now he's president of a dog breeder association in Champagne. He's coming with his wife, flying, and his wife is handling the medical phase, and you are late. So you ask the wife, and she tells you no decompensation. You look at the lab tests, which are okay. The Doppler US is okay. Well, you fix the next appointment in 6 months with lab tests and Doppler US. The duration of appointment was 15 minutes, and you are very happy because you save time. Second case figure, the same day, another day, and the same patient. And you have a little more time. The wife is late. So you ask the patient, and he doesn't find his prescription. He doesn't find his lab results. He shows distractibility, euphoria, slight disorientation over time. Eventually, the wife arrives. And so you discuss with her, and you discover that she is handling all the administrative load, the medical issues, and the dog breeder association and everything, but this is hidden, and this is between them, and they don't say anybody. The duration of the appointment is 45 minutes. You prescribe an extensive workup, you diagnose minimal HE, but it took you a lot of time, and usually you don't have time. So what do we need to increase the diagnostic of non-clinical HE? The screening with animal naming test is very interesting. Animal naming test is a new test. It is the only one that you can perform every day very quickly, 1 to 2 minutes. The consign is name the largest number of animal names in 1 minute. And so it takes you 2 minutes, and you can see if your patient displays neurocognitive disorders or not. And the cutoff is 20. Under 20, the result is not good. And if you try to do that, you are able to screen a non-clinical HE in your outpatient clinic. And after, we will see what you do. The third issue with the diagnosis is the brain reserve. As you know, your patients have a lot of other causes to have neurocognitive disorders, including for NASH patient diabetes, HTA, dyslipidemia, and for other patients, for example, alcohol, which gives neurological symptoms also. And so the idea here is that you have a patient which is slow, but you can say, well, the diagnosis is not minimal HE, but something else because of the cause of this liver disease, or even because something else, and something else is because of aging. And mild cognitive impairment, in fact, which is an intermediate state between aging and dementia in elderly patients, is really a differential diagnosis of non-clinical HE, which is very difficult to make. Here you have the cognitive functions on this slide that are altered in MCI on the left and MHE on the right. You can see that some of them are the same, some of them are not, especially language and memory dysfunction in MCI, and motor speed and accuracy in MHE, if you know things and you have time to see this, and there is always a matter of time. Here, what you can use, because sometimes you think it's MCI and it's MHE, is to try ammonia-lowering therapies, especially if aging, because if this works, you will say, well, it was minimal HE, and not aging and MCI. And this is a way to increase your diagnostic performance of minimal HE. Last thing is the cognitive reserve, and this is very hard. Well, we can call it also basal intellectual potential, which is worse, but still, that's what it says. As you know, white colors, so patients with a high intellectual level can mask and hide their symptoms. And maybe the best example is this patient of 40 years old. This is a true story, who came to see us at our Blitz outpatients clinic for the diagnosis of hepatic encephalopathy. He displayed HCV cirrhosis, cured, non-decompensated, and he wanted an appointment, but everybody was telling him he had no troubles. So he found by himself the address of the clinics and he came. He was a writer for a famous politician, and his only complaint was that his slowing when reading books, Critique de la raison pure, it took him 2 days instead of 1 to read it. Of course, nobody was believing it, but he says that he was really bothered in his job. In fact, he had typical MHE. We treated him only with lactulose with a resolution of symptoms, and he's doing very well. And so that's a typical cause of underestimation because he had a high intellectual profile. So what do we have at our disposition? Well, we can have, if available, neuropsychologists, but we won't have it. Ammonemia is elevated. Remember, no HE without elevated ammonemia. So elevated ammonemia should make you think maybe you have a patient with non-clinical HE. Multimodal MRI or EEG is not available, but the therapeutic test is a very good thing to try if you suspect minimal HE. So to conclude, what I suggest you for a definition of non-clinical HE in order to decrease the underestimation is a patient with cirrhosis, cognitive disorders without neurological disease, and at least one item, either hyperammonemia, easy to perform, or history of clinical HE, which really can reveal MHE, and improvement with plasma ammonium lowering therapy, lactulose or rifaximin. So if we summarize, you suspect minimal HE, or even for everybody, you screen minimal HE at your outpatient clinics with animal name tests, and in case you prescribe ammonemia and maybe plasma ammonia lowering therapy if ammonemia is elevated, and you will increase your diagnostic performance. Take-home message, non-clinical HE is often underdiagnosed, should be diagnosed. We really need to use screening tests, easy to perform, and the therapeutic test is a good option. And as we didn't have time, we didn't address the question of the reversibility of minimal HE, which is still unsolved, but this should urge you, because it's not sure it's reversible, to really diagnose and try to diagnose minimal HE. Thanks a lot for your attention. And this is the French team for the HE recommendations last year. Thank you very much.